about hematology. And in our next, I guess about an hour and 10 minutes or so, we're going to talk about these three general topics. The first thing we'll talk about, obviously, is going to be anemias. And if you don't know your anemias, today's the day. You're going to learn them. In the next hour, you are going to leave here understanding these anemias. I guarantee it. And I'm so confident, and I'm going to guarantee it, because I know that I can teach a kindergartner to diagnose anemias. And if I can do that, then you're a lead pipe cinch. So we'll talk about anemias. You're going to learn them today if you don't have a good grasp of them. The next thing we're going to look at is one platelet problem. And I'm going to tell you, it's not real common. But when this platelet problem walks into your office, you've got to nail it. And you've got to know what to do. So I want to make sure that happens. And then the third thing we're going to talk about is interpretation of CBCs. Because I'll be honest with you, if you're like the students I precept or my colleagues in practice, I frequently get a CBC from them and they'll say, hey, Amelie, tell me what you think about this. And so I'm going to walk you through 3 CBCs and then we'll take another break. All right? So let's get going. Here's how I'm going to win my bet. And I know I'm going to win my bet. If you're struggling with anemias, I know why. It's because you're missing some facts in your knowledge base. And the minute I put those facts in your knowledge base, all of a sudden the light bulb's going to come on and you're going to see it. So we're going to go through some lab background. And the other reason we're going through lab background is because I have never met an NP student who said, I got so much in lab interpretation in my NP program, I feel confident to look at labs. No, I've never met somebody who could tell me that. So we're going to put some background in your brain because you need to be able to hit the ground running when you get to your clinical practice. And then we'll launch into the anemias. And then we'll look at that platelet problem and we'll look at some CBCs. All right, so let's get going. And so I got to make sure everybody is on the same page. How do you know that somebody is anemic? Like, how do you know they have anemia? Well, it turns out that you are going to look at, because your colleagues look at, these 3 things. And if one of these 3 things is reduced, then by definition that patient has anemia. Look at the 3 things we look at. We look for a reduction in red blood cell count. We look for a reduction in hemoglobin, or we look for a reduction in hematocrit. And if one or more of those is reduced, then we toss out the word anemia. All right, so that's what you're going to look for. So I want you to look at my numbers. And I want to know if you think this patient is anemic. I'm looking at the RBC count. On a CBC, it's just plain old RBC. RBC count 4.3, within normal limits. Hemoglobin 11.5, a little bit reduced. Crit, within normal limits. So only one of them is abnormal. Is that patient anemic? By definition, they are. All right, so they are anemic. Finish this sentence for me. Rules are made to be broken. But I have 2 rules, and probably 3, that I never want you to break. Here's rule number 1. Anemia is never normal. Anemia is never normal. It's never normal to be anemic. And if you're anemic, there's something going on with that patient. And I would tell you that your job in clinical practice is to figure out what in the world is going on with that patient. So rule number 1 says anemia is never normal. Here's rule number 2. Normal lab values don't necessarily mean that everything is normal. Take a look at these situations. Now, I really think that when you work in primary care, you should be paid more than people who work in specialty care. That's not the way it is. It's just the opposite. The reason I think you should be paid more to work in primary care is because in primary care, you got to keep your eye on all the balls. And if somebody comes in with a COPD exacerbation and they go to pulmonary medicine loads them up on steroids, and the patient says, what about my diabetes? And the pulmonary specialist says, go see primary care. But in primary care, when we have a patient who's got a COPD exacerbation and we give them a steroid, we'll say, your blood sugar's going up, here's what I want you to do. So I think you have more work in primary care. I just do. And I guess I'm prejudiced, but I just do. So because you've got to keep your eye on all the balls, I want you to realize that there are a lot of things that can affect a patient's H&H. And so we need to talk about how some of these things can affect a patient's H&H. So take a look. Dehydration. I want to know whether the effect on H&H is no effect. Does it make it go up? Does it make it go down? With dehydration, what effect on the H&H? Goes up. Chronic kidney disease, what effect on the H&H? It makes it go down. How come? 2 reasons, Amelie. Okay, tell me those 2 reasons. Here's the first one. When you have a sick kidney, it probably cannot produce erythropoietin. And what's erythropoietin? It's the substance that makes you make red blood cells. So if you don't make erythropoietin, you probably won't make so many red cells, so you'll probably be anemic. But the other reason people with chronic kidney disease are often anemic, if not always, is because when you have a chronic disease, any kind of chronic disease, and it's out of control, the H&H drops. The red blood cells don't live 100 or 120 days like they're supposed to. They die young. And when you have red cells that are dying young, then the kidney and the bone marrow have to work even harder to make more. And so sometimes they just can't keep up. And so with chronic kidney disease, we definitely see a drop in the H&H. With that little spiel I just gave you, you should be able to answer number 3. A diabetic whose A1C is 11.3. Well, listen, you could be a first-day LPN student, and you know an A1C of 11.3 is not normal. And so for the learned people in this room, if your A1C is 11.3, your chronic disease called diabetes is way out of control. And you know what else? When your blood sugar is 350 on a good day, it puts so much stress and strain on the red blood cells that they die young. You know people like that, right? People have extraordinarily stressful lives die young. So the same thing happens with red blood cells. And if red blood cells are dying faster than you can replace them, H&H is going to take a dive. Look at number 4. It says anabolic steroid use. Well, you know what anabolic steroids, moderate to high use? Testosterone, as an example. You know what can happen? It sends the red blood cells production into high gear. And what happens is they produce more red blood cells. What happens to the H&H? It goes up. So as part of routine care, in patients who are in moderate to high doses of any kind of anabolic steroid, we typically have to get a CBC to check on them. And occasionally, the H&H goes really high, like a 60 and 20. What do we do with those patients? Well, first of all, what are they at high risk of? A stroke. Your H&H is 60 and 20. I'm scared of you. So if your risk of a stroke is up there, what do we do with those patients? Listen to the term, therapeutic phlebotomy. We draw off 2 units. We draw off 3 units. So lots of things can make the H&H go up or down. Number 5 says pregnancy. Pregnancy creates a state of dilutional anemia. Same number of red blood cells are in that pregnant woman, but now there's more fluid. So it produces something we call a dilutional anemia, which means in a pregnant patient, it's not unusual to see the H&H drop, which is why most of them are on iron. We'll talk about that in a minute, or a few minutes. And then look at your last one. Does age have anything to do with someone's H&H? Well, kind of. If your patient is 88, I don't think her bone marrow is as robust at making red blood cells as it was when she was 28. You agree? Yeah. So I don't expect an 88-year-old to have an anemic H&H because she's old, but I expect it to be on the lower side of normal compared to somebody who's 28. Everybody got it? So here's your take-home point from this slide. A lot of things can affect someone's H&H. Do you remember what rule number 2 was? Just because somebody's lab is normal doesn't mean everything is normal. Take a look. A patient has stage 3 COPD. That means they're on at least 2 meds and they still don't breathe so well. See the labs below. RBC count, 4.3, good. 12.4, good. 37.2, good. Is this patient anemic is my first question. No. Question number 2. Is everything normal? The answer is no. If you have stage 3 COPD, you're in a state of chronically deprived oxygen to your tissues. That's what you are if you're a stage 3 COPDer. And you know what your body does to try to fix itself? It shoots out more red blood cells. Do you really think a stage 3 COPDer is going to have an H&H of 12 and 37? Oh no! Those are the people who walk in with H&Hs that are on the upper limits of normal or even outside the upper limits of normal. You follow me? Normal labs don't always mean that things are normal. So, you worried about this patient? I'm worried about him. I'm worried about him because this guy's H&H ought to be higher than it is, and it's not. So you got it. Can you make yourself a little note as to why? Right? So it should be higher because he's in a state of chronic oxygen deprivation to his tissues. You know, the body is such a miraculous and marvelous thing. No matter how you try to break it, it tries to fix itself. And that's exactly what happened. So I'm concerned about this. I'm a snoop around, and as you're going to hear next hour, I'm a worrier. So I'm worried about this patient. Anybody else worried? Yeah, I'm worried about this patient. We'll talk some more. All right, well, with that little primer, my bet is on the line right now. Because I made a bet with you, and I told you that today was the day you were going to learn anemias, even if you just struggled with them and you don't know them. Today's the day. Right now is the time. And I'm so convinced I can teach you to diagnose anemias because I can teach a kindergartner. And if I can teach a kindergartner, you're a lead pipe cinch. And here's why I can teach a kindergartner to diagnose anemias. Because the 2 things you need to know to graduate from kindergarten are exactly what you need to know to diagnose anemias. You need to know about big and little, size, and you need to know your colors. Size and color. That's what you're going to use to diagnose your anemias. Let's talk about them. When we look at anemias and we talk about cells, the suffix we use is cytic. So if a patient is anemic and their red cells are too little, we say they have a microcytic anemia. Microcytic. Your cells are too little, and you anemic person. If you're anemic and your red cells are the perfect size, we say you have a normocytic anemia. You're anemic, but your cells are perfect in size. Some people have anemia, and their red cells are whopper big. We say you have a macrocytic anemia. So every anemia in the world is characterized by the size of the red cell. The place you go to look for the size of the red cell, since it's so darn important, is on a CBC, and you look at the MCV. That's what's going to tell you the size of the red blood cell. The second thing that characterizes every anemia in the world is the color of the red blood cell. Now let me ask you, what makes a red cell red? Hemoglobin. How much hemoglobin is in that red cell is what makes a red blood cell red and not green. Well, if a patient's anemic, they might be anemic because their red cells don't have enough hemoglobin in them. And when we talk about the color of red cells, we use the suffix chromic. So if you're anemic because your red cells don't have enough hemoglobin in them, they're low in color, we say you have a hypochromic anemia, a hypochromic anemia. Some people are anemic, but their red cells have the perfect amount of hemoglobin in them. We say you have a normochromic anemia. And the last one doesn't happen often, but some people have red cells that are packed with hemoglobin. And if your red cells are packed with hemoglobin, we say you have a hyperchromic anemia. So every anemia in the world is characterized by size of red cells and color of red cells. And on a CBC, if you want to know the color of the red cells, you look at the MCH. So here's where you ought to be right now. You ought to be saying, okay, Amelie, to diagnose anemias, I have to know cell size and cell color, right? Which means on a CBC, I need to look at the MCV size and MCH color, right? Right. So every anemia in the world is characterized by size and color. Let me give you some examples. If somebody had small red cells and not enough hemoglobin in them, we would say they had a microcytic hypochromic anemia, small pale cells. Another example, suppose a patient had anemia. His red cells were normal in size and normal in color. How would we describe his anemia? We say he had a normocytic, normochromic anemia. Here's another example. Suppose a patient was anemic. Their red cells were big and they had the perfect amount of color in them. We would describe that anemia as a macrocytic, normochromic anemia. So every anemia in the world is something cytic and something chromic. Is everybody with me? All right, let's keep going. Now that you know that, I have two questions for you. Here's your first one. I want to know if you think this patient is anemic. The three things you're going to look at, look right here. RBC count, hemoglobin, and crit. So I want to know if you think this patient's anemic. And clearly they are because all three measures are low. So the second question I have for you is this one. In this anemic patient, what do his red cells look like? When I look at the MCV that tells me size, 86.5 is normal. So how about normocytic? Write that down, normocytic. And what do the red cells look like with the MCH? Normochromic. So the red cells in this anemic patient are normocytic and normochromic. Is everybody with me? All right, good job. Let me put in the rest of the basics in your brain, and then we're going to take care of some patients who have anemia. H and H, got to know that. You knew it before you walked in here. MCV, size. MCH, color. If you didn't know it before, you know it now. The next one I got to put in your brain is an RDW, a red cell distribution width. And I don't know why they called it that, because that means nothing in my brain. Red cell distribution width. It says that a normal red blood cell, it's okay if the variation in size is less than 15%. Well, you know, that still doesn't really talk to my brain. Here's the way I want you to think of RDWs. I want you to think of RDWs like donuts. All right, donuts are pleasant to think about. They're even more pleasant to eat. So let's talk about donuts. I want you to think of donuts when you hear RDW, and here's why. When you go into, let's say, Shipley Donuts, Okay, we in Houston. If you're in South Louisiana, we might talk about Mesh's Donuts. Maybe if you're in the Northeast, we might talk about Dunkin' Donuts or Krispy Kreme donuts. But think of donuts. Your expectation when you buy a dozen donuts is never that every donut in that dozen you just bought is the exact same size. That's never your expectation, because donuts are not the exact same size. Oreos are, but donuts are never. You're okay with that dozen donuts you bought as long as the donuts are pretty close in size. And when you buy a dozen, there are always a few that get dinged and smushed. But they're just about the same size as the donut next to them. And as long as that's the dozen donuts you got, you good with it. But suppose you went in to buy a dozen donuts and you got 11 donuts and they tossed in a donut hole as the 12th thing you bought. You wouldn't be happy. You wouldn't be happy because a donut hole is too little. Well, the same is true of red blood cells. Red blood cells are never the same size. They're not like Oreos. They're like donuts. They're pretty close in size. And as long as the red cells vary by less than 15%, it's all good. Once the red blood cells begin to vary by more than 15%, there's trouble. And your job is to figure out what kind of trouble is going on. So let me make sure you got my point. I got a question for you. Here it is. Plate number 1 is on the left. Plate number 2 is on your right. I want to know which plate has a normal RDW. Plate number 2. Plate number 2, because even though plate number 2 has just donut holes, they're all about the same size. Now look at plate number 1. RDW is going to be greater than 15%, which lets us know something's up with this patient, because your red blood cells are not supposed to vary that much in size. So that's an RDW. All right, and I'm going to show you why that's important in a minute. The rest of the things you just have to know are these. A serum iron level. Like, why in the world you need to know about that? Because a serum iron level lets you know how much iron is in circulation right now. We need to know that sometimes. It's like a DIG level. How much DIG do you have in circulation right now? We also need to talk about a serum ferritin level, because sometimes you need to know how much iron is in storage. All right? Not in circulation, but in storage. And so let me give you something that will help you know about storage. Let's pretend you have a 40-year-old woman. She's got a big old fibroid, and every month when she has menses, she bleeds very heavily. You know what happens? The serum iron level drops. And the minute the body recognizes, whoa, the serum iron level is too low, let me fix it. Because remember, no matter what you do to your body, it tries to fix itself. So here drops the serum iron level. The body says, let me fix it. It goes into storage. It grabs iron, puts it into the serum, and the serum level rises. It's normal again. Here comes the next month. She bleeds very heavily. Serum iron level drops. The body says, whoa, it's too low. Let me get some out of storage. It pulls it out of storage, puts it in the serum. Serum level rises to normal again. But at some point, when the serum iron level drops and the body tries to fix it by going into storage, there's nothing left. That's when the serum iron level is low. It remains low, and the serum ferritin is low. Got nothing left. So that's a relationship. Sometimes we need to know serum iron, but sometimes we need to know serum ferritin. I'm coming back to those points. What's a reticulocyte count? Well, what's a reticulocyte? A reticulocyte is an immature red blood cell. Where do those red blood cells come from? The bone marrow. You know, I tell people all the time, Unless you've had leukemia or you've taken care of people with leukemia, you probably take your bone marrow for granted. Because every minute of every hour of every day of every year, your bone marrow is on its job. It's always looking for trouble. It never takes a day of vacation. And one of the things your bone marrow is looking for is trouble related to an anemia. And when your bone marrow says, whoa, she's anemic, it begins to increase the number of reticulocytes it makes. Because a reticulocyte is an immature red blood cell. It only takes 2 to 3 days for that little reticulocyte to become a completely mature red blood cell. 2 to 3 days, that's it. So, why do we measure a reticulocyte count? Because we want to know if that patient's anemic. Is the bone marrow able to do its job? Is the bone marrow able to produce red blood cells when the patient needs them most? Let me ask you a question. Suppose a patient was anemic and the reticulocyte count was low. Where's the problem? The bone marrow. You got it? So sometimes we measure a reticulocyte count. It lets us know about the ability of the bone marrow to make new red blood cells when you need them most. Well, the poor old peripheral smear. Nobody ever uses a peripheral smear, and it might just be your very best friend. Because here's what a peripheral smear is. It's when a patient or med tech, like Jeannie, takes a drop of your patient's blood, puts it on a microscope slide, puts a slide under the microscope, and looks at one high-powered field. And they look at that high-powered field and they tell you everything they see. And sometimes they see small, pale red blood cells. Sometimes they see an intracellular parasite in that red blood cell. What might that be called? Malaria. Look at those sickle-shaped red cells. So a peripheral smear is a verbal, a written example, a written thing of what they found when they looked at that high-powered field. So it's a visual description of the red blood cell that the med tech saw when he did a peripheral smear, she did a peripheral smear. So you should always consider one of those in a patient, any patient with anemia, unless it's iron deficiency and you know it's that and there's nothing else it could be. Otherwise, you ought to be getting a peripheral smear. So here's rule number 3. If the peripheral smear description of the red blood cells doesn't match the MCV and MCH values, I want you to consider that the patient doesn't have one anemia. They have more than one anemia going on. Let me just show you. So here's an example of a peripheral smear. The med tech looked in one high-powered field and they told you what they saw. And this med tech told us, Amelie, when I looked in one high-powered field, I saw, look, macrocytic, normochromic red cells, and I saw microcytic, hypochromic red cells. They see 2 different kinds of red blood cells. That's your clue. This patient has 2 different anemias going on. So try to wrap your brain around that concept, but it's an important one. You need to consider doing peripheral smears unless the anemia diagnosis is a slam dunk. All right? So hold on to that thought. Here's the last one. I saved it for last because it's the hardest one to wrap your brain around. It's called a TIBC, a total iron binding capacity. And the way that I want you to think about a TIBC as a laboratory value is just like this. I want you to look at the palm of your hand. And I want you to imagine that the palm of your hand is a red blood cell. And each of your fingers, hopefully you have 5, each of your fingers is an iron binding site on the red blood cell. So your red blood cell right here should have 5 iron binding sites. Now let me tell you a secret about iron. Iron hates to swim around and around and around in the bloodstream. Iron is always looking for a home. And if iron can find a home, meaning an iron binding site, it's never going to leave home. So, if you have a red cell with 5 iron binding sites, and your patient has plenty of iron in his bloodstream, all of those molecules of iron swimming around in the bloodstream are going to look for and find and sit in an iron binding site. And once they get in there, they're not getting up. So if you don't have iron deficiency anemia going on, all of your iron binding sites are full of iron. You see it? If you had an iron deficiency, not enough iron, you would have plenty of iron binding sites on those red cells where iron could come and sit if you just had enough iron. So listen to it. The TIBC doesn't tell you how much iron is bound. It tells you about the red cell's ability to bind iron. So think of it like this, because I find it hard to wrap your brain around. I was in the grocery store one day buying eggs. And I know I do the same exact thing you do when you buy eggs. Don't you open a carton of eggs to look in them to see if one is broken before you buy it? Yeah, you do. So I open a carton of eggs and I'm like, bazinga, this is a TIBC. Take a look. Excuse me. The carton on the left, it doesn't have a single place to safely put an egg. It's full of eggs. Its capacity to put another egg in the carton on the left is very what? Low. Excuse me. Look at the carton on the right. It doesn't have an egg in there. The capacity to put an egg in the carton on the right is what? Very high. So when the count is low, the capacity is elevated. All right, so if the iron count is low, the capacity to bind iron is very elevated. If the iron count is high, we got plenty of iron, she's not anemic, the capacity is very what? Low. It's the opposite of what you think. We call that a reciprocal relationship. And think about that one for a little while, because that one is hard to wrap your brain around too. Everybody got it? All right. So those are the basics. Those are the basics, and you got to master them. Look at your red cell indices. H and H, you should know those. MCV and MCH, got to know them. And RDW, how much they vary in size. Not the size, but how much they vary in size. Look at these other really important labs. You got to know the difference between